surgical training of both the technique and the technology, and is president of the UK Holmium User Group. And many of you on the call today have heard about the HUG Group, and very much how this has developed the training of this great technique as well. He has mentored many HoLEP surgeons both in the UK and across the world as well, and hope some are joining today and some are good who will join in the future as well. He has been training this in the last 5 years and part of the Urology Specialist Advisory Committee. So with that, I will hand over to Dr. Aho to present. We will have a Q&A session at the end of it as well, where we'll be able to ask any questions. So over to you. Thank you very much again.
Well, thanks very much for the introduction, Marcus. Welcome, everybody. Good evening. I'm in Cambridge in the UK at the moment. I'm just going to share my screen here so I can give this presentation. So thanks to Boston Scientific for asking me to present this evening. And I've been asked to talk about HoLEP and how it compares to TURP, but I'm going to talk much more than just how it compares to TURP. I started HoLEP personally in 2002 when I was in New Zealand, working with Peter Gilling and Mark Faundorfer, who invented HoLEP. So I started there, and I have not done a TURP since I started doing HoLEP, apart from one randomized study where I had to do some TURPs. I hope I can convey the reasons why I have completely abandoned TURP in favor of HoLEP as I give this presentation. So here are my disclosures to begin with. The outline of this evening's talk is going to be, first of all, why consider HoLEP over TURP as a replacement, I would say, rather than just offering both side by side. I'm going to try and explain why there's no need to even do that. Once you can enucleate endoscopically, I see really no reason to continue with resection or vaporization at all. Secondly, I'm going to look at areas where I would say, without a doubt, according to the evidence base, HoLEP is the best in its class. So I'm going to mention some particular advantages of HoLEP over every other endoscopic technique. And then I'm going to talk about advances in HoLEP technique itself, particularly the En-block technique that a lot of you will have heard of, no doubt. And I've sort of developed my own particular version of that, which I'm going to show you in a video. I'm going to talk about advances in HoLEP technology, which is very important. The equipment that we use, the laser, the morcellator, a lot of things have changed since I started doing HoLEP, and it's completely revolutionized the operation. So I'm going to mention that. And then finally, I'm going to talk about some improvements in HoLEP patient pathways. How do we actually manage these patients after the surgery? It's not all about the surgery. It's also how we manage the patients afterwards into their recovery phases, and I'm going to talk about how that has been streamlined as well. In particular, I'm going to reference and explain how we do day surgery HoLEP. So to begin with, these days we're quite fortunate, and our patients are, because there's a wide variety of different BPO procedures available. I'm not going to go through all of these, but I will just say that with HoLEP is an endoscopic enucleation. So as an anatomical enucleation of the prostate, it is the most effective, most durable procedure that we can offer for disobstructing a benign prostate. But it has less side effects than the other versions of anatomical enucleation. So therefore, robotic or laparoscopic or open approaches. And it may have a few complications rates that are slightly higher than the minimally invasive techniques, but it is certainly more effective and more durable than those. Now, if you are like myself and you're a urologist who has a special interest in treating men with BPO or benign prostatic obstruction, it's very helpful to have a procedure which can easily deal with the most complex BPO scenarios. So this includes, patients who are anticoagulated, men with very large prostates, more than 100 cc's, men who've had previous failed BPH procedures, other types of procedures that haven't worked too well, men with perhaps large immobile intravesical median lobes that may not be particularly well suited to things like urolift or maybe green light vaporization, men who are in chronic urinary retention with impaired detrusor function, They may not do so well with other procedures, but with HoLEP, as you're going to see, they do incredibly well. Men with high pressure chronic urinary retention as well, they do incredibly well after anatomical enucleation. So what I would say here is one reason for considering adding HoLEP to your armamentarium as a surgeon or as a service is that it is capable of dealing with the most complex BPH procedures. So when all else has failed, HoLEP is often the saving grace, the one thing that can salvage the situation. And that has often been the case in my own experience. So, and these days we have to consider not just technical things like the size of the prostate and whether the patient's in retention or not, but we really have to put at the forefront of our decision making what the patient wants from their treatment. What are their priorities? So they may prioritize things like a short hospital stay with HoLEP. It is possible to get up to 90% day stay rates. I'm going to talk about that later. A lot of patients want to be discharged from hospital without a catheter. Not all, they can't do that with all BPH procedures, but with HoLEP, if they stay one night in hospital, 90% will go home the following day without a catheter at all. A lot of patients just want the best possible outcomes in terms of LUTS improvement, and they want it as soon as possible. They don't want to hang around and wait for weeks or months to get the maximal effect. They want it straight away. That is possible. That happens with HoLEP in virtually everyone. A lot of men prioritize stopping their BPH medication. BPH medications cause a lot of side effects, particularly sexual side effects with the 5-ARIs. And in fact, 5-ARIs have a higher risk of causing sexual dysfunction than a lot of the BPH procedures do. So with HoLEP, and this is often something that's not talked about, but virtually 100%, virtually all of the patients that we offer HoLEP to are able to permanently stop their BPH medications afterwards. That is something to be remember and ask patients if that is what they want. A lot of patients prioritize that quite highly. Obviously, a lot of patients want a quick return to work and normal activities, and virtually all men who have HoLEP after 2 weeks are back to all normal physical activities. Those who are in urinary retention, their main priority almost always is to get rid of their catheters. And as you'll see, this is one of the best-in-class features of HoLEP. The catheter-free rate for men in catheter-dependent urinary retention after HoLEP is 98 to 99%. That is better than any other endoscopic BPH procedure. A lot of men value highly durability. A lot of men are dragged in, kicking and screaming by their partners to have an operation. They really don't want to have an operation on their prostate, and you sort of get one chance. They give you one chance to get it right. If they don't want to come back for another procedure, then HoLEP is a great operation for them because it is highly durable. Very, very low reoperation rates, even up to 20 years after the procedure. I suppose a lot of people will say, well, HoLEP has high retrograde ejaculation rates. So what about, men who want to still be able to ejaculate normally? I'm going to mention briefly under techniques, ejaculation sparing HoLEP. It is possible to preserve the ability to ejaculate, or at least significantly reduce the risk of retrograde ejaculation with modifications to the HoLEP technique. So, what is HoLEP? HoLEP is the endoscopic version of a simple prostatectomy. Simple prostatectomy has been around, obviously, for decades and decades. This is just to show you that is the case. This is a beautiful image, I think, from a friend of mine in Luton in the UK. This is a patient who had a HoLEP, had incidental prostate cancer, ended up having an MRI afterwards as active surveillance for the cancer that was found. This is the image. You can see the virium termen sitting there on its own. The entire transitional zone is completely gone. There is a huge cavity there. There is absolutely no transitional zone remaining. There is no adenoma remaining whatsoever. And BPH, of course, should be thought of as a benign tumor of the transitional zone. It makes sense to remove the entire thing. There's not many other tumors, but even benign tumors, where we'd only remove part of the tumor, because of course it's going to grow back if we do that, or there is a risk of it growing back. With HoLEP or anatomical endoscopic enucleation, it is a complete, clean anatomical enucleation of the entire transitional zone. That leads to some significant advantages for this procedure. Now, just one point of difference between HoLEP, TURP, and other procedures is exactly that. We completely disobstruct the prostate when we do an anatomical enucleation. And if you look at PSA reductions post-surgery, if you look at HoLEP papers, you can expect across the board an 80 to 90% reduction in PSA after HoLEP. We are removing usually about 70 to 80% of the prostate is removed. With resection, whether it's monopolar, bipolar, whatever it is, any type of resection, you look at the literature, there's about a 45 to 65% reduction in PSA. We don't remove as much of the prostate with a resection. And with vaporization, it's similar. Again, we don't remove as much of the prostate as we do with endoscopic enucleation. Does that matter? Well, this is a urinary flow rate in a patient post-HoLEP. Now, this is a bit misleading because this is actually, the flow rate has gone way above the scale here. But if you look at this, what's the Q max? It's almost 70 mils per second. I mean, that's enough to literally blow the urinal off the wall almost. So this has been known about for some time, that if you do an anatomical enucleation, you are completely disobstructing the prostate. You're ending up with somebody who can void like it better than a teenager can. But, does that matter? I would say that yes, there is some significance to this because HoLEP has been shown in this. This is the first randomized study of HoLEP versus TURP that came out of New Zealand. And interestingly, they did urodynamic studies before surgery and then 6 months after surgery. And they found that urodynamically, there was superior disobstruction of the prostate urodynamically with HoLEP compared to TURP. I mean, when you think about what we're doing to the prostate, of course this makes sense. We are completely disobstructing the prostate with enucleation. We are not really ever doing that with resection unless somebody does a complete resection down to the capsule all the way around, which I know in the UK doesn't generally tend to happen. So I would say that one of the advantages of complete disobstruction is not just that we can get flow rates so amazingly high, because the patient doesn't really care so much about how good their flow rate is necessarily, but they do care about the improvement in their symptoms. Now, there is good level 1 evidence now that HoLEP provides better symptom improvement, superior symptom improvement than TURP or resection or vaporization techniques. So just a bit of evidence here. I'm going to go through this quite quickly, but I just wanted to show you that there is published evidence that confirms this. So in this meta-analysis, a huge number of RCTs were considered for this, and in the case of HoLEP, it was the only procedure that was shown to lead to superior IPSS improvements, symptom improvements in men compared with monopolar TURP. The other procedures they looked at, PVP, green light vaporization, and bipolar TURP, they had no differences in symptom improvements compared to monopolar TURP, but HoLEP had a better symptomatic improvement. And here's another meta-analysis which shows exactly the same thing. It wasn't just flow rates that were better for HoLEP compared to TURP. It was also the symptom scores were improved to a higher degree with HoLEP compared to TURP. Other benefits for HoLEP over TURP, as in virtually every randomized study that has been of TURP versus HoLEP, is that HoLEP has less blood loss, shorter catheter time, shorter hospital stays, lower transfusion rates, so lower bleeding complications essentially, and therefore lower lengths of stay as well. Here's another HoLEP versus TURP meta-analysis showing exactly the same thing. So not just better improvements in flow rates and post-void residuals, but better improvements in symptom scores as well for HoLEP compared to TURP. Now we'll move on now to what is HoLEP best in its class for. Well, there are three areas where there is no debate, I would say, that HoLEP is the best endoscopic procedure that we have. So it is the best in its class for catheter-free rates in men with catheter-dependent urinary retention. I'm going to go on and explain and show you some of the evidence for this. It is no doubt the most effective and safest endoscopic procedure for dealing with men with larger prostates, more than 80 cc's, and that's reflected in the EAU and AUA guidelines as well. And it is the most durable endoscopic procedure that we have for BPH. So let's have a look at HoLEP for retention. The first study here is a study that we published from Cambridge, and this was in the first 500 men that we had who had HoLEP. More than half of them had catheter-dependent urinary retention. None of them had urodynamic studies. They were not pre-selected by urodynamic studies. Some of them would have had detrusor failure or weakened detrusors. And what we found is that when we offered HoLEP to these men in retention, more than 98.5% of them became catheter-free after HoLEP. So virtually everyone who was in retention became catheter-free afterwards. The second paper is an American one. It's very interesting because they did urodynamic studies before HoLEP in men with urinary retention, and then 6 months later after surgery as well. And they found that even in men who had non-neurogenic detrusor hypocontractility before HoLEP, so those who had weakened detrusor muscles on urodynamics before HoLEP, all of those men became catheter-free after HoLEP. These are men that if you were offering a TURP maybe 10 years ago, or maybe even now, if you did urodynamics on these men and you found they had weakened detrusors, would you offer them a TURP? Maybe not. You might say to them, well, TURP may or may not work. If you offer HoLEP, you can tell them that HoLEP, you can pretty much guarantee HoLEP will work. It will get them catheter-free, regardless of their detrusor function. The really interesting thing about this paper is that even in men who had acontractile bladders, so there were a group of men who had no bladder contractility on pre-op urodynamics, they still went ahead and did HoLEP. 95% of those men also became catheter-free post-HoLEP. Some of them were voiding by Valsalva, but they were voiding and they were catheter-free. And one thing I haven't mentioned here, which is really interesting with this paper, is that about 80% of men who had weakened detrusors before HoLEP, when they repeated the urodynamics after HoLEP, they found that about 80% of those men, they had improved detrusor function after HoLEP. So the old dogma that once your bladder is damaged, the bladder muscle is not working. Once it's been under pressure for so long, it's never going to work again to the same degree. That is wrong. If you completely disobstruct the prostate, the bladder muscle recovers. Okay, so this is a new thing that we've only started to discover because we can now completely disobstruct the prostate. That is a major advantage for HoLEP, the fact that you can rely on it to get men catheter-free who are in retention beforehand. So this is just a small HoLEP experience that we looked at. We looked at 50 HoLEP patients and consecutive HoLEP patients who were in retention versus 50 consecutive TURP patients who were in retention in Cambridge. Those who had HoLEP had much bigger prostates, so a lot of more tissue was removed. But despite that, those who had HoLEP had a shorter length of stay. They were in hospital 1 day as opposed to 3 days on average with TURP. And the interesting thing, as I was just talking about, 99.5% of those men who had HoLEP became catheter-free afterwards versus 80% of those who had TURP. So there is a big difference, I would say, between TURP and HoLEP in terms of how effective it is for treating urinary retention. Here's just a quick slide to show you the differences between different BPH procedures and their success rates of treating urinary retention in terms of getting men catheter-free. HoLEP at the top is well ahead of everything else. So in our experience now, because we know that 99% of men will become catheter-free after HoLEP, we don't bother doing urodynamic studies in men without neurological problems who have urinary retention. It's pointless, because how are we going to try and identify on urodynamics the 1% of men where HoLEP won't work? Urodynamics is unnecessary in men with non-neurogenic urinary retention if you offer HoLEP. Okay, we're going to move on to larger prostates. These are the EAU guidelines. HoLEP is the only endoscopic procedure which is recommended for men with prostates of any size above 30 cc's. Everything else has a limitation to it, mostly of 80 cc's. Aquablation now you can offer aquablation up to perhaps 120, 150 cc's, but not really beyond. HoLEP, the man with the largest prostate I've done a HoLEP for successfully was 750 cc's. So that once you're experienced as a HoLEP surgeon, the sky is the limit. So HoLEP is not just the advantage of HoLEP for men with larger prostates is not just that it is safe and effective. Also, the outcomes are pretty much independent of the prostate volume. So here's a couple of papers. One was comparing men with having HoLEP with less than 80 cc prostates versus more than 80 cc prostates. There was no difference in any outcome. No difference in symptom scores, durability, complication rates, length of stay. No differences whatsoever between those two groups. The men with the larger prostates did just as well as the men with smaller prostates. The paper by Boxall was a Cambridge paper. We looked at men with very large prostates to see if there were any differences. So we looked at the differences between men with prostates between 80 and 200 cc's and those with prostates more than 200. We did find some differences there in the very large group, more than 200 cc's. There was a slightly greater fall in hemoglobin in the larger group. They had a slightly longer length of stay in hospital, but there were no other significant differences whatsoever. So really, it doesn't really matter how big the prostate is. You would expect the same outcome for your prostate, for your patient, whether their prostate is more than 200 cc's or less than 80 cc's. This is just one of the landmark papers by Rainer Kuntz from Berlin, the first and largest randomized study so far of HoLEP versus open prostatectomy for very large prostates. The interesting thing is there were no differences whatsoever at 5 years of follow-up in terms of IPSS, flow rates, residual volumes. No differences in urethral stricture rates either between those procedures or bladder neck contractures, and there were no reoperations whatsoever in either the HoLEP group or the open prostatectomy group up to 5 years of follow-up. To bring it more up to date, this is just a flavor of showing you what about robotic-assisted simple prostatectomy in the USA. There's not much HoLEP done. More urologists, I think, are offering robotic simple prostatectomy. But this is a systematic review, meta-analysis compared to HoLEP. Robotic-assisted simple prostatectomy had a longer length of stay, longer catheter time, higher transfusion rate, but overall, in terms of longer-term outcomes, there were no differences in flow rate, symptom scores, post-ward residual volumes, or post-op PSAs. So there's a bit more comorbidity or slightly higher bleeding and longer catheter and length of hospital stays with even robotic simple prostatectomy compared to an endoscopic simple prostatectomy like HoLEP. And then the final area, as I said earlier, where I think HoLEP is no doubt best in its class as an endoscopic BPH treatment is durability. So the longest published follow-up that we have for HoLEP is at 10 years. From the late Professor Al-Hilali's group in Canada. They had a 0.7% reoperation rate for regrowth of BPH 10 years after HoLEP. So you can pretty much guarantee with HoLEP that it's going to last a lifetime. So whereas everything else, vaporization, resection, TURP, UroLift, PAE, resume, anything else, it can be a bit like just kicking the can down the road, as we say in the UK. It may just be, dealing with the problem at this point in time, but the problem resurfaces later. With HoLEP, it is literally like hitting the ball out of the park. The patient will never see that problem again. They will never be in retention again, never need BPH medication again. This is a table I'll just leave up briefly to show you, and what I've used here for these figures is the landmark studies for all these procedures. So the randomized studies for UroLift, for resume, PAE, aquablation, a recent TURP series, a relatively recent HoLEP series. You can see there that the symptom score, the reduction in or improvement in IPSS is higher with HoLEP than anything else, as I said earlier. The flow rates, as expected, are much higher after HoLEP than anything else. Sure, the retrograde ejaculation rates are high if you do a full HoLEP, but if you do an ejaculation sparing HoLEP, which I'll talk about later, you can reduce the retrograde rate down to about 10%, which is the same as resume and probably around the same ballpark almost as aquablation as well. And the durability is much greater with HoLEP than any of those other procedures. So what about the downsides of HoLEP? So there's a few kind of almost urban myths that have developed around HoLEP, because a lot of people who don't do HoLEP say, oh, but there's a high incontinence rate, or, oh, but the sexual dysfunction rate is high, there's high retrograde ejaculation. So there have been some modifications that have improved these complication rates, which I will talk about soon. So in terms of urinary incontinence, the actual persistent urinary incontinence rates, meaning any pad usage a year after HoLEP, is less than 0.5%. It's actually very low. And early apical release is an improvement in HoLEP technique that has reduced the risk of transient urinary incontinence to less than 10% of any incontinence at all after HoLEP, even on day one. So that is an important improvement in technique. Erectile dysfunction is not actually high at all. Actually, it's not actually high for any BPH procedure, to be honest. It's around 2%. And if it does happen, PDE5 inhibitors, in my experience, work very well for post-op erectile dysfunction in about 70% of men. So overall, the rate of permanent erectile dysfunction that doesn't respond to medication post-HoLEP is less than 1%. It's not high at all. So the retrograde rate, as I said, if you do a full HoLEP, it is virtually 100%. That's true. But if you do an ejaculation sparing HoLEP, you can reduce it to about 10%, which is similar to a lot of the mists that are available these days. So what about recent advances in the technique? I've kind of referred to some of these already. I'm going to show you just a video, highlights really, to illustrate what I call the Tev technique. I didn't name it that after myself, somebody else did, but it stands for, this is using the Moses laser, by the way. It stands for T incision assisted early apical release with V incisions to do an en-block technique. This is a man with urinary retention. He's got 175 cc prostate on MR. We're using the Moses 2.0 laser from Boston Scientific. Energy 1.2 joules, frequency 60 hertz. It's relatively low power. It's only 72 watts that I'm using. This, you can see it's a very large prostate, a big intravesical component there. That I'm looking at where the sphincter is. The first step of the operation is to get into the enucleation plane on usually the right side of the veru when you're looking at the screen. So I'm a right-handed surgeon. I'd always start on the patient's left side. It's easier. You want to get into the plane. This is the easiest part of the prostate to find the enucleation plane. There are often stones in the plane. You can see the stones, some stones there. I hope you can see that there's a sort of a dark line, which is the enucleation plane. That's how I'm identifying where to go. I'm now going to do the same thing on the other side. I'm just going to break through the mucosa at the side of the veru to get into the enucleation plane, and then I'm going to go up. Not all the way to 12 o'clock, but I'm going to go up to about 10 o'clock on this side. And then I'm going to go across the top of the veru there to join those two areas up, to open up the posterior plane. I want to get well into the enucleation plane here, underneath the adenoma. And then I'm going to go back up a little bit higher now, up towards 12 o'clock. There we go. The next step is what I call the T incision. Okay, this is something that I don't think anyone else does yet, but I recommend this for people who want to learn the en-block technique. I think this makes early apical release a lot easier if you're learning it for the first time. The T incision means you're just dividing, you're going up to 12 o'clock, going straight up vertically towards the capsule at 12 o'clock, which is there, and then over the top on both sides in the shape of a T. Okay, so this is to define and find the plane anteriorly. We found the plane posteriorly. We now want to find the plane anteriorly. And then by doing that T incision, when we come back out through the sphincter there's the sphincter, we can much more easily see these kind of pedicles, I will call them, of mucosa. We want to divide these well away from the sphincter. And I think personally that doing that T incision helps you. You've got something to aim for as you're going up towards 12 o'clock. If you don't do that T incision, I find personally it's very difficult to know where to cut up to. But you can see here, I've already opened the plane up above here at the top there, and I've opened it up down below, and now it's quite easy just to connect these two areas up and to detach. I'm coming back to see this. See, there's a very small bridge left there now, but it's easy to see it. And I can divide through that now very safely, well away from the sphincter. So what I'm doing here is I'm detaching the apical area of the prostate, the most distal part, away from the sphincter very early on. See, the sphincter's there, I'm checking it. It's still covered completely by mucosa. It's completely preserved. I'm doing exactly the same on the other side now, and it's the T incision in the middle at 12 o'clock that is helping me to know exactly where to cut. So now I've detached the apical tissue well away from the sphincter. Now I'm going to work up anteriorly over the top of the prostate. I'm going to go backwards and forwards, side to side, smoothly in the anterior plane, until I reach the bladder neck at 12 o'clock. And this is actually fairly straightforward. The only anatomical landmark here, though, is the actual enucleation plane. So you have to learn how to identify where the plane is. As I said, the way you can tell where it is that there's a sort of a dark line. As you peel the adenoma down from the roof, you can follow the capsule. And then as you get close to the bladder neck, you see these vertical fibers. There's a few vertical fibers there, and now I'm breaking through. I've broken through already at 12 o'clock to the bladder. That is a moment of relief for the surgeon, because once you've broken through at the bladder neck, you know where that is. It's very easy then to come down both sides. You can see the median lobe just off to the left there, which is in the bladder, actually. It's very intravesical. So what I'm now doing is coming down the side. I'm looking for where the ureteric orifice is as I come down towards the base of the bladder. I can't see it yet, so I'm going to just keep coming back a bit further. Keep coming down a bit further down the side. Coming all the way down the side, so I'm just dropping the adenoma down from the roof and down from the sidewall. You can see with this holmium laser, this is the Moses technology I'm going to talk about later, it's extremely hemostatic. You know, what we call the pay-as-you-go hemostasis is fantastic. First pass hemostasis, so you just pass over any arteries and it pretty much coagulates them as you go. You don't have to stop and keep coming back. See, there's an artery, but you can see how well that coagulates. That was quite a big bladder neck artery, and within seconds that is coagulated using this laser. So I would strongly recommend, if you don't have a high power holmium laser and you want to do HoLEP, I would definitely recommend using a high power holmium machine like this one. And I would strongly recommend using pulse modulated holmium. That means in the case of the luminous laser from Boston, using the Moses technology, because that helps to alters the characteristics of the pulse of the holmium laser in a good way that helps you to enucleate. It speeds up the enucleation, and it also coagulates extremely well. And this is what allows us to do 90% of cases as day stays. This laser is fantastic. It's very, very hemostatic, very little bleeding, even in this prostate, which is remember, this is a 175 cc prostate. And, I'm going relatively quickly here because I don't have to keep stopping to coagulate vessels. Now, this is what I call the V incision. So now that I've come down each side of the adenoma, I'm sort of cutting downwards here and medially. So I'm doing that. You can see one side of a V here. When I do the same on the other side, it's going to be a V shape. I'm cutting downwards and medially down both sides to narrow the posterior attachment of the adenoma. There's the ureteric orifice on that side. I was just checking where that was. It's fairly close. So as you come down the sides towards the base of the bladder, you need to check where the UOs are to avoid those. Here I'm just coagulating anything that looks like a vessel, even though there's no bleeding. And then I'm now crossed over to my right-hand side, the other side of the adenoma. And now I'm doing the sort of what I call the other limb of the V from the other side. I'm cutting downwards from the bladder neck down, and As I'm coming down, I'm starting to go medially. So I'm ending up with a V shape. And I just keep doing that down each side, this V incision. And each time I do a V, the adenoma is moving further up towards the bladder. And I don't have to push at all. So this is one of the benefits of using a holmium laser to do enucleation. You don't have to do any real mechanical dissection with the scope. You can use the laser, you can use the energy source to do all the work for you. And that is advantageous because when you're using the laser, you're getting very good coagulation, very little bleeding. If you use other lasers, which don't allow you to enucleate so well, you have to do a lot more blunt dissection. So there's the adenoma, it's gone to the bladder. There's the sphincter, it looks perfect. 131 grams of tissue came out. Enucleation time, only 30 minutes. That's 4.5 grams per minute. Morcellation took 15 minutes, very fast these days. That patient stayed in overnight. His catheter was removed early the next morning, 6 o'clock. He voided well. He was discharged around midday, no catheter at all, 175 cc prostate. So that is my current technique for en-block with early apical release. Again, the TEV technique, T incision assisted early apical release with V incisions. So en-block is a relatively new technique. We used to do what we call an incisional technique or a 2 or 3 lobe technique where we made bladder neck incisions. So there are a number of papers. What's the advantage of learning en-block if you're learning HoLEP? Well, it's faster, basically. It's faster than a 2-lobe or 3-lobe technique, and there's a number of papers here that show that. This paper says it's actually twice as fast. Doing en-block versus an incisional technique, they found was twice as fast. And there were less bleeding issues as well, because if you're not having to do any bladder neck incisions, as you saw in that technique, you're not cutting through the adenoma at all. You're working in a largely bloodless plane all the time. Of course, there are going to be perforating veins and arteries, especially near the bladder neck, and you saw a couple of those, but you can see how well that holmium laser with Moses technology coagulates those. So I would say the main advantages of en-block versus the traditional incisional technique are that it is faster, and significantly faster, and it is more hemostatic. There's less bleeding. So again, better for day stay, if that's what you're looking for. Now, ejaculation sparing HoLEP. This is a different technique altogether. So traditionally, and if you look at the literature, there's all kinds of descriptions of doing ejaculation sparing, BPH surgery, whether it's resection or vaporization or enucleation. I have found personally that if you follow this technique where you preserve all of the tissue near the veru and a cuff of tissue, including the veru in the middle of it, all the way around circumferentially, you have to preserve distal tissue. That's important. It doesn't matter how much you open the bladder neck. The bladder neck is not important for ejaculation. You see how far up I'm starting this enucleation. This is a small prostate. So there's another thing that people often forget. You can do HoLEP does not have a lower size limit either. HoLEP has been shown in the first randomized study versus TERP. That included patients with prostates from 30 to 80 cc's, and there were significant advantages for HoLEP even in men with standard size prostates, up to 80 cc's, in terms of shorter hospital stays, less bleeding, quicker recovery, and higher durability. So people often think of HoLEP as being an operation only for men with larger prostates. It can also be, I offer it for men with any size prostate, to be honest. As I say, I've given up TURP more than 20 years ago when I started doing HoLEP. But the point here is with ejaculation sparing HoLEP, you have to preserve a cuff of tissue, which you can see there, distally. You can open up the area of the bladder neck and you can go out to the enucleation plane proximally, but you have to preserve the area around the verum montamen all the way around circumferentially. And if you do that, you will end up with about a 10% risk of retrograde ejaculation, which is very similar to resume. At times, to achieve this outcome, you might have to do more of a resection. So you can see here, I'm sort of cutting a bit of tissue out here using the laser. But even if you're kind of cutting smaller bits out like this, it is still very hemostatic, as you can see. There's virtually no bleeding there. So just to switch to quickly to show you the same case, but some still photographs of what I'm leaving behind. You can see the pre-op appearance. You can see the post-op appearance, with including where the verumontamen is, and you can see that I hope that I've left a ring of tissue distally. And this man, he did not have any change in his ejaculation whatsoever afterwards. The downside of doing ejaculation sparing HoLEP, as you might expect, is it's not as durable as a full HoLEP. And it's perhaps, although it's never been studied properly, it may not be as effective, I would say, for disobstructing men in urinary retention either. So if you've got somebody who really wants to be catheter free, I wouldn't necessarily encourage them to have an ejaculation sparing HoLEP. This is a bit more like what you'd end up with after a standard TERP, I suppose, with quite a lot of apical tissue left behind. Now, there have also been some significant advances in technology which have made HoLEP a lot faster and I would say safer to perform as a surgeon. Now, first of all, I'm just going to show you the different energy sources that are currently being used for enucleation. So we're starting with bipolar here. There's a range of different bipolar probes in use these days, but this is one of the commonly used ones still, I believe. You can see it's quite a lot bigger than a laser fiber. So it's not as precise, it's not as nice. And when I speak to colleagues and friends who do enucleation with different energy sources, I always ask them, how do you decide which energy source you're going to offer a particular patient? The one thing that most surgeons I know who offer HoLEP, let's say, or laser enucleation versus bipolar, they don't tend to offer or want to use bipolar for men with very large prostates, perhaps more than 150, 200 cc's. They would prefer the laser. I think the thing is, this is slower. Using a bipolar instrument like that is slower than using a laser fiber. I think it's technically probably a little bit more difficult as well. You can't really see the plane so well as you're using the energy source. There's quite a lot of disturbance. There's a lot of bubbles when you activate the energy source. As compared to the holmium, which you've seen a good video of already, it looks quite different. We go over to green light. It's obvious. The obvious difference there is this is a side firing fiber, not an end firing fiber like holmium. Side firing fibers, I personally think, are more difficult to use to do an enucleation. And the thing about green light is you really do have to use goggles or glasses when you use this. You don't have to really with holmium. So the vision is not as good. Your vision may be impaired by the glasses a bit. There's bubbles, as you can see here, when you're activating the green light laser. There's often a sort of glow, an orange glow. You can't see as clearly as you can with a holmium what's happening when you've got the laser active. So I don't think personally it's as good as a holmium for enucleation. Then we move on to thulium, the traditional thulium laser. There's, I'm going to go back. The thulium laser cuts like a hot knife through butter. It is not the ideal tool for, this is it here in the middle. It's not the ideal tool for an enucleation. An enucleation, anatomical enucleation, is like peeling an orange from the inside. You want a blunt instrument. You wouldn't peel an orange with a knife. You use your blunt finger because it's easier to get into the right plane and to follow it. If you use a knife, you're cutting in and out of the plane. This is like using a knife to do an enucleation, I think, using the thulium, because this is the continuous wave thulium, by the way. It's a bit confusing now because there are 3 types of thulium that are all different, but this is the original continuous wave thulium. It chars the tissue. There's a lot of bubbles coming out the end of that fiber. It's not nice. I've tried it myself and I don't like it. The thulium fiber is the 4th video here. Oh, I can't see this because my there's something. Oh, whoops. Something. Oh, sorry. What have I done? Sorry, I think I've lost my presentation now. I'm going to go. I don't know what I've just done there. Sorry, I was trying to show myself what I was supposed to be looking at. Let me go. Oh, here we go. So the thulium fiber This is not me. This is a friend doing this, and he's doing a lot of blunt dissection here using the scope to push the adenoma off. The reason for that is that, once again, this is cutting like a knife through butter. When you're using the energy source, it's a little bit clearer than using the continuous wave thulium, but there's still bubbles, there's still charring. It's not as nice a view. So a lot of surgeons you'll find that use TFL for enucleation, they're doing a lot more blunt dissection than we would need to do with HoLEP. So what's the main principles here? I would say, as I said earlier, using the orange analogy, you want to have a blunt instrument to do an enucleation of the prostate. It's just like peeling an orange from the inside. I would say that out of all those energy sources I've shown you, HoLEP is the best blunt instrument. It means that you can get a very nice, clean enucleation. You're not cutting in and out of the plane. You are able to follow the plane much more nicely than you are with thulium or thulium fiber. So what about the differences between high power and low power holmium then? So all these videos are showing holmium for enucleation. The first video here is low power holmium. And you can see, I would just say it is quite possible to do a HoLEP with a low power laser. And this is just 40 watts. But it is much slower. The hemostasis is not as good. Okay, the reason for the hemostasis not being so good is that the coagulation zone around the fiber is not very wide with low power. This is a higher power laser, 60 watts, but it's normal holmium. It's not pulse modulated. It's not Moses. So you can see here, I hope, that the coagulation zone around the fiber is wider with this laser than it is with the low power laser. So the hemostasis is better. It's faster than the slow one, but the best one of all is the third one here, which is Moses. You've already seen a longer video using Moses, and you could see there that I was working very quickly. It was very hemostatic. So the coagulation zone with Moses is even wider, which is useful for coagulation and also speeds up the procedure. So I would say, as an analogy here, that Moses technology gives two main advantages over standard holmium. It's more effective, Moses, and more efficient at gaining hemostasis. And the analogy here is I would use is to think about a paintbrush, painting a wall with brushes. If you've got a low power laser, it's like painting a big surface like a wall with a narrow paintbrush. You can do it, but it's going to take time. The Moses is like using a very wide paintbrush or even a roller to paint the wall with. Much faster, much more efficient. And the other thing is the hemostasis is much better, I would say, with the Moses technology with pulse modulation. So it's much more like using a rollerball, for instance. If you're comparing it to TURP, it's much more like using a rollerball for coagulation rather than something small like a Collins knife or something. There's going to be a big difference between those two things. And this is just another analogy using, the ice cream, scooping out an ice cream. Once again, if you had one of these tubs with a wooden spatula thing, you could scoop all of that out in one go, but it would be more difficult and it would take longer than using, a purpose-designed scoop. So I think I would say that the low-power holmium is a bit like the narrow spatula here, and the Moses technology is much more like the scoop. It's faster, it's more effective, more efficient. So what does that mean for your patient, though? So it means post-operatively, it means much better hemostasis afterwards as well. It's more predictable. The hemostasis after using a Moses laser, afterwards, the urine looks uniformly, usually very clear. This is consistent, it's reliable, it's reproducible. So this allows us to much more feasibly be able to offer day surgery if we're using an energy source that's very hemostatic and we can trust it to be hemostatic. There is some evidence, randomized trial evidence here. One of these papers is using the Moses technology. One is actually using a quanta laser, what they call the virtual basket, also pulse modulation. But with the Moses technology, there was found to be a 43% reduction in enucleation time just by using Moses technology as opposed to high power holmium without Moses. So Moses technology is, I think, worth the investment for your hospital. It's more expensive than non-Moses technology, but it does mean it speeds up the procedure enough that in an all-day list you could add on an extra case in the day with the time that it saves you. And as I said earlier, you can reduce your length of stay quite considerably to day stay even, much more likely if you're using this technology. It's not just lasers that have improved in terms of technology, it's also morcellators. Um, the older fashioned morcellator used to be what we call a reciprocating blade that went backwards and forwards, sorry, that went in and out, the one on the left. All the newer morcellators these days are oscillating blades. The blades move backwards and forwards. The oscillating morcellators are much faster. There's a few tips for morcellation technique as well. We now do a lot more morcellation within the prostate fossa rather than in the bladder. That helps to keep the tissue on the blades, helps to prevent it from falling off. So if you've got little bits like this that are very smooth, bring them back into the prostate fossa to morcellate. That will help you. And invert the blades. We're doing upside down morcellation here to pin the bit down almost against the prostate fossa. That also helps with these, what we used to call beach balls, smooth nodules that are difficult to morcellate. Okay, and finally, I'm going to mention improvements in patient pathways. So the really one thing that really stands out with, well, if you offer HoLEP, and let's like me, I offer not just HoLEP, but I offer Resume, Urolift, Aquablation now as well. And if you have a patient that comes into your clinic pre-op and they tell you they want a HoLEP, it's very simple. All you need to do is an IPSS score if they've got no catheter, a flow rate and a residual volume. You don't need to even measure their prostate volume, because HoLEP is obviously suitable for men with any size prostate. Once you're experienced as a surgeon, you don't need to do a flexible cystoscopy. You don't need to look at, is the median lobe enlarged or not. It doesn't matter with HoLEP. And as I said earlier, if you've got a man in urinary retention, you don't need to do urodynamics, because you know that there's a 99% chance you'll get them catheter free. So the preoperative workup for men who come to you wanting a HoLEP, as long as it's as long as it's appropriate for them, and HoLEP is appropriate for virtually any man with a prostate, to be honest, as long as the anaesthetist can give them an anesthetic, they are suitable for a HoLEP. If they want a HoLEP, they don't need all these extra investigations. These are the sort of things that you would do if the patient was considering, a minimally invasive surgical technique, though. It's important to select the patients well for some techniques, but you don't have to be so fussy for men who want HoLEP. And then finally, this is our day stay pathway that we use in the NHS and the public system. It has tasks here for the nursing staff, for the surgeons to abide by. But basically, you can get up to 90% of men home the same day if you really try and you really want to, and they are expecting this and they are motivated to do it. What happens afterwards is that they'll go back to the day stay ward. I always leave continuous bladder irrigation running after surgery, even if the urine looks clear. I ask the nurses to run that at full speed, regardless of the color of the urine, for an hour at least, and then to start to turn it down and just to maintain the urine at a rosé sort of color. And then the nurses then judge that for themselves. They turn off the irrigation when it's rosé on its own. As soon as they get the irrigation off, the patient gets changed to a leg bag. They sit out of bed, they walk around, mobilise, get used to the catheter, and then they go home. Now, I work in the NHS at a day surgery unit, which is 40 minutes away from my main hospital. This is only a day unit. It does not have any inpatient beds. We've been doing HoLEPs at this place now for 2 years, and I personally have not had a single patient yet where we have not managed to get them home the same day. So if you have a well-motivated nursing team, recovery team, surgical team, everyone's invested in this, the patient knows what's going on, they want to go home the same day. The one thing that does hold you up with 10% of patients are social factors. The fact that they live alone, or they can't get transport home, or something like that. But as long as their social factors are sorted out beforehand, you can almost always get them home the same day. But in my experience, we send them home with a catheter, and then we have to get the catheter out later. So they either come back to clinic 2 or 3 days later. These are all 4 men that were done on the same operating list with HoLEP 2 days before. They've come to clinic to have their catheters out. These are the colours of the urine. What we do here is we fill their bladders with saline until they feel full. Then we take the catheter out. Most men will pass urine within half an hour. They'll have a post-void residual scan. If it's less than 150, they leave the clinic, they go home. That works very safely. During COVID, we started asking patients to remove their own catheters at home, and I just told them simply to use a pair of scissors to cut the inflation channel here to release the fluid from the balloon. I think it's safer for them to do that than try and use a syringe themselves, because we often put even up to 80 mils of fluid in the balloon to hold it in the bladder after HoLEP, if it's a very big gland. And often if the patient is using a syringe to try and deflate the balloon, they may not completely deflate the balloon before they start pulling on the catheter. So if they cut the inflation channel here, they can then watch the fluid come out of here, and once the fluid stops coming out, they know that the balloon is empty. Then they can pull the catheter out safely. So if the patient's going to take their own catheter out after day surgery HoLEP, I ask them to do this 5 days later. And touch wood, we have not had anyone yet who's failed their TOC 5 days afterwards when they've removed their own catheter. Some people who use MoLEP abroad in the USA, Amy Krambeck, for example, here, are doing day-stay HoLEP, and they're removing the catheters before discharge. So these are same-day discharge without a catheter after HoLEP, and they've had a good success rate with that. But that involves quite a lot of investment of time and with specialist nursing staff in the few hours after surgery, which I haven't been able to replicate myself in the NHS yet. So, as a conclusion, I would say that HoLEP is an invaluable tool in any BPH specialist toolbox as both a primary and a salvage treatment. Virtually anyone with a prostate is suitable for HoLEP. Technique and technology have combined to reduce operating times, catheter times, morbidity, and to facilitate day surgery. And I would say, maybe controversially here, perhaps one procedure can, in fact, cater for all BPH scenarios and satisfy virtually all patients' requirements. And I would say, if there is one procedure that we have, it is HoLEP. So thank you very much for your attention. Sorry, I haven't left much time for questions, but I'm very happy to take any questions if we have some.
Thank you so much for that. Yeah, no, we do have a few questions. I'll put some of them together so that we can just cover them. The first one was, in the retention patients, does the 1% of patients who fail with HoLEP have smaller prostates and urodynamic detrusor failure?
Good question. Actually, there doesn't. The only pattern that we found with those very small numbers that fail to void are that they have all been, in my experience, very elderly. So all over 85. Often not very mobile either. So, but we've not really found any other common factors in terms of prostate volumes or anything else, or detrusor function. As I say, we don't even bother doing urodynamics, so we don't even know about what the detrusor function is actually before HoLEP in that group of patients. But I would say it's more likely to be the very elderly, less mobile patients where it may fail.
That's great. Thank you so much for that one. Training education, you talked a bit about the Moses technology enhancing, how you advance with that. Couple questions here around it. In a good practice, what suitable prostate size is a starting point, and which technique must be followed?
Yeah, very good question. So I would say this is very clear. With our HoLEP user group guidelines for mentorship and learning, we say select the ideal patient to start with is a patient with a prostate volume of between about we actually formally say 40 to 80 cc's. So it's somebody with a slightly larger prostate because the plane is going to be a bit easier to find. And it's also men initially on your learning curve that are not in urinary retention, don't have catheters in already, have not had previous prostate biopsies, have not had a previous BPH procedure. So you want to make it as easy as possible for yourself. Now, in terms of is there a better technique to learn when you're starting? Is en bloc easier or harder to learn than three lobe technique? I don't think there's any evidence in any direction there. I recommend to people that I'm teaching to watch videos of en bloc versus incisional technique, and to tell me which technique they think they want to learn, which one makes more sense to them. Because some people will come to me and say, right, I want to learn the three lobe technique, that I can understand easier. And some will come to me and say, actually, I want to learn en bloc because that I understand that technique, having watched the video, and I want to learn that. And at the moment, I would say more of my registrars, more of my trainees come to me and want to learn en bloc than want to learn three lobe or two lobe technique. But it's up to you. There's no evidence either way, and there's no rules either way. I would suggest watch videos and go for the one that you think makes more sense to you and that you can understand.
Great, thank you. And I'll add in a link into this also to our Educare platform as well, which we do have our education that goes through, which is supported by yourself and many of our HUG group members as well. Question on here regarding, isn't prostate volume measurements operatively important to assess OR time of the procedure?
Yeah, I probably was a bit blasé with my comment. I mean, these days, because I've done quite a few HoLEPs now over the years, I don't bother really with getting bladder scans, prostate scans to tell me what size the prostate is, because I know that in my experience, unless the prostate is absolutely enormous, more than 200 grams, it's going to take less than an hour. So, but when you're learning, I would encourage you to get prostate scans on everyone, so that you can plan and you don't get any surprises when you get into the operating room. So yes, I would say that when you're starting, and as long as you want to, as long as it is more comfortable for you to know the prostate volume before you go to theatre, you should carry on getting the prostate volume. So I have colleagues who are very experienced HoLEP surgeons who always insist on still getting prostate volumes formally measured before they do an operation. Again, that people differ after a while. It depends on your comfort levels and what you want to do. So I wouldn't say you shouldn't do prostate volumes, but it's not absolutely necessary for everyone to have a prostate volume in some people's experiences after once they have a lot of experience with HoLEP.
Right. And just while we're talking about prostate size, when we look at day case, is there an upper limit, you would say, when you come to prostate size?
Well, in our practice at Ely, the day stay unit, actually, we're now going up to 200 cc's. And sometimes, to be absolutely honest with you, if I'm not happy with the hemostasis, completely happy with it after the HoLEP, I will go in with a roller ball and I will do a bit of focused diathermy around the bladder neck and around the mucosal edges near the virio as well. So the key thing about technique for allowing day stay, surgical technique rather than technology, is to get the best possible hemostasis that you can at the end of the procedure. And if that involves getting a roller ball out, get the roller ball out, if you're on a day stay unit. But if you've got Moses technology, and unfortunately at that hospital, we don't have our Moses technology there. So I do use the roller ball a bit. But if I had the Moses technology, that would reduce the chance of needing the roller ball.
Right, thank you. Just a couple more if you're okay for time.
Yeah.
Do you think if you lose supporting holding the adenoma place throughout the procedure by changing from late to early apical release, do you think, it's about the adenoma pretty much in that supportive side during the procedure, do you do your apical release earlier or later?
Yeah, right. I think I understand what this person is asking, because all I would say is that I think most of us who are experienced in HoLEP, in Europe at least, would encourage people and teach people the early apical release technique, because our belief is that it helps to preserve especially the mucosal lining of the sphincter. And we think that is important for early continence. And our theory is that that we used to have higher rates of transient urinary incontinence after HoLEP when we didn't do early apical release. And the theory is that perhaps if we didn't release the apex from the sphincter early on, even though we weren't pushing very much with the instrument, we probably were stretching the sphincter because we were not detaching the adenoma away. And as we were going around the adenoma with the instruments, we were probably, without even realizing it, putting pressure on the sphincter by stretching it. So that's why we now try and detach the apical tissue early, so that when we're doing the rest of the operation, we're not stretching the sphincter at all, and we're preserving the mucosal covering. So the thing that I would say is that if you find that for some reason, whether you do the T technique or whatever you do, to do the early apical release, if you struggle to do it early, if you can't actually see where you're supposed to be going early, don't worry so much about it. Carry on, do the enucleation, and often it's actually easier to see those bridges of mucosa after you've mobilized the rest of the prostate. It's sometimes harder to do an early apical release than a late apical release, but we would always encourage people these days to learn the early apical release and try and do that as often as possible. But if you can't do it, because you're not quite sure where to cut near the sphincter, you should not cut at that time. Carry on with the operation, then come back and have a look at it, and it might become easier if you do it later. It's much more important. The main priority is to preserve the sphincter, whatever that takes. I hope that answers the question.
Yeah, I think that covers a lot of detail there. Just question about your TWOC protocol, standard patient that goes home with a catheter. Do you have a dedicated post-op TWOC clinic as well?
We do, but it took a lot of work to get that in at Addenbrooke's, and I know that in other hospitals it's probably difficult to arrange that as well. But it's really important. So we have a nurse-led TWOC clinic 5 days a week now at Addenbrooke's, my main Cambridge NHS hospital, and that's really focused on post-op TWOCs. So people who go home the same day with a catheter in, they then come back to that clinic at about 3 days later, 2 or 3 days later, and they can have the TWOC there. And as I say, what I do personally, and what I've asked most of our nurses to do, is to, when the patient comes in for the TWOC, they fill the bladder with saline until through the catheter until the patient feels like they need to pass urine. Then they take the catheter out. This saves a huge amount of time. And if you pre-fill the bladder, then take the catheter out, most men will pass urine within half an hour. And usually pass urine very well if it's 3 days after a HoLEP. And then, within 40 minutes, the patient has had their TWOC and they're gone. They're home.
Great. There's quite a few questions here about learning curve. And we talked about that. Just go back and just talk through about how many cases you would advise before they go solo.
Yeah. So the way that the HoLEP user group in the UK, the way that we have described our recommended learning curve or training program is that we would advise people first to either come to a course in Cambridge. I'm not just trying to advertise a course because we get lots of people at this, but we do an annual course where we spend 2 days in detail talking about all aspects of HoLEP technique. So go to a HoLEP course, wherever it is, learn about the technique, and then choose a mentor. So in the UK, we have mentors who are experienced HoLEP surgeons. We would then recommend you go to the mentor's hospital, watch them do a whole day of operating, see a whole lot of cases, bring your theatre sister as well. That's a good idea, so that our nurses can show your nurses, give them some tips and tricks about setup and where do you put certain things, how do you set up the Morse laser, how do you set the laser, all those kind of things. And then as soon as possible after that visit to the mentor's hospital, the mentor would then go to your hospital. And the ideal is to have 2 days back to back, and we would give you guidance about how to select the patients. The first day we'd say 4 cases. 4 cases, they would, the first 2 would be less than 40 cc's. This is to just get you used to using a high power laser in the prostate. And we would hope that those smaller prostates would probably just be median lobe enucleations. They're probably not going to be 3 lobes, just the median lobe. So you get to do a little bit of morcellation. You get to do pretty much all the procedure on your own with us standing behind you, pointing out and giving you tips and tricks. And then, so 2 of those cases, and then, one small case, less than 40, and then 2 between about 40 and 80. And those cases, you having been to the course and watched us operate for a whole day, we're hoping then by that stage, we can just stand behind you and point on the screen and you can do most of the operation. But it's important that we can scrub in as well. So in the NHS, we can get honorary contracts. We can scrub in to help you with our hands, get our hands in there if we need to. I think that's important as well. But this is a model that we've used abroad, not just within the UK. We've gone elsewhere to teach other people. And then the second day would just be 3 cases, all between 40 and let's say even a bit higher, up to 100 cc's, where we're hoping you, the trainee, would be doing pretty much every step of all of those operations with us there supporting you. So
Right.
that's it. After that,
Perfect.
90% of men, 90% of urologists, I should say, would feel comfortable continuing on their own after that sort of training program.
And I've answered a couple of those also with our link to our Educare platform as well, so that they could to enhance that as we do with our hands-on in Dusseldorf and other training facilities as well. So last 2, if you're okay for time there. Settings, you mentioned 2 and 45. Is that your go-to for?
1.2 and 60 hertz. 1.2 joules and 60 hertz is what I use. So it's actually, considering that we have 120 watts potentially available to us with the Moses laser, we're actually only using 72 watts. So I think there's a move these days for most experienced HoLEP surgeons as well to turn down the power a bit. We don't need huge power to do this operation safely. We need enough power. And I think because of the Moses technology, we don't need so much power now. It's actually more the shape of the bubble, which is what the Moses technology gives us. That's more important than turning it right up to maximal power now.
Yeah, and I think you're right there. The difference is on that learning curve as you start and as you become that skilled with the technology as well. With a patient with anticoagulants, do you stop them straight away or later on due advice for pelvic floor exercise perioperatively as well?
Oh yeah. Okay, I'll start with the pelvic floor exercises. So yes. So this is very important. And I started doing this when I was reading literature about radical prostatectomy, where there was very good, well-designed studies that showed that men before radical prostatectomy who were doing regular pelvic floor exercises for a couple of weeks or so, they had less early urinary incontinence than men who didn't do the pre-op pelvic floor exercises. And I found exactly the same thing with HoLEP. So all the patients if I see the patients myself, or if my team does, my registrars or whatever, before booking them for surgery, we will always give them information and teach them how to do pelvic floor exercises, encourage them to start doing those preoperatively. And in my experience, it's a massive improvement. It halves the rate of transient stress incontinence if you teach men and they do the pelvic floor exercises for even just a couple of weeks before the surgery. That helps a lot to reduce the risk of transient urinary incontinence. So too does the early apical release. And then the second part, sorry, the question I'm trying to remember, was about anticoagulation. So with anticoagulation, I don't get worried about aspirin at all. I don't get worried about clopidogrel or Plavix that much either. Those antiplatelet agents are not particularly bad. And I never stop aspirin. I will stop Plavix if we can, but in men who've had coronary stents who can't stop their clopidogrel or Plavix, I will offer to do the HoLEP without them stopping it at all. And so far, touch wood, I have had one patient who's had a post, where we had to not take them back to theatre, but had to do bladder washouts after their HoLEP, but who had an enormous prostate. But no, I've done more than 50 HoLEPs now on men who've not stopped clopidogrel with only that one patient who had a bladder washout on the ward afterwards. Everyone else was no difference than if we had stopped it. So clopidogrel, not a problem. DOACs, though, they can be a massive issue. So with DOACs, if the person who prescribes the DOAC says we have to restart it as soon as possible afterwards, I'll always get them to stop it 3 days before surgery. I will always stop it before surgery, the DOAC. And I will leave a catheter in. So this is an important trick. Whatever surgery you do for BPH, if you leave the catheter in afterwards for a week, allow the prostate to start to heal a bit, avoid a lot of abdominal straining the day after if you've twocked them, so the patient can just relax. They don't have to try and pee for a week. That is magic for allowing you to restart the DOAC or the warfarin early on. So this is a really important tip, I would say. This is something I discovered by accident. So in somebody who I want to start rivaroxaban or apixaban or whatever, you can start it the night of the operation often if you leave the catheter in for a week afterwards. So I would recommend trying this in patients, even if you're doing TURPs still. Try this. It really does help to reduce the risk of post-operative bleeding. And for warfarin with HoLEP, if I always ask the person who's prescribed the warfarin, can we bring the INR down to 2? Are you happy with that? Because I'm happy to operate and do a HoLEP with a patient with an INR of 2, even up to 2.5. I hardly ever stop the warfarin completely now. I normally just leave it. I don't bridge with heparin. If we can bring the INR down to 2 for the perioperative a few days, but just before the operation and for maybe a day after, then that is fine. I think there's more risk of bleeding if you stop the warfarin, you bridge it, and then you have a patient who's restarting warfarin and on low molecular weight heparin. That is more of a recipe for bleeding than just carrying on with the warfarin and bringing the INR down to 2 for the perioperative period.
I think, did you cover that one? Just say, yeah, there's another question just came out saying, should keep using dutasteride post-operatively.
That's it. No, I didn't cover that. So I don't ever stop dutasteride or finasteride before. I don't start patients on it just to reduce the risk of bleeding during surgery, like with some people do with TURP. I don't think it makes any difference. So it's not necessary to start the 5-ARIs before HoLEP. It doesn't help to reduce operative bleeding or post-op bleeding. And if they have a HoLEP, I will stop all their BPH medication from the time they have the HoLEP onwards. So right. I don't leave them on it afterwards at all. Whether it's alpha blockers or 5-ARIs, whatever it is, Cialis, they stop all those things as soon as they've had the HoLEP.
Okay, great. And just one final one. Any size difference when you look at prostate size? I think I know one of the answers is regarding 2, 3 lobe and en-block, depending on the prostate size that you do.
Yeah, this is a good question. This is a question I was asking when I first saw en-block as well. I was thinking that there would be an upper size limit for en-block because I was thinking that I know that in men with very large prostates, sometimes the prostate itself, the adenoma, is wider than the bladder neck is. And I was thinking, how are you going to try and squeeze that through the bladder neck somehow if you've taken it out en-block? And I thought there must be an upper size limit. But what I've found in practice, there doesn't really seem to be an upper size limit for en-block. I do en-block now with early apical release. I use that Tev technique that I showed you for everyone, apart from men who want ejaculation sparing, of course. And I found that there's occasionally you will end up with a huge wide adenoma that you can't push into the bladder. And if you can there's two options here. You can either start the morcellation within the prostate fossa. As I say, normally now, a lot of us who do a lot of enucleation, we often do a lot more morcellation within the prostate fossa now than we ever used to. It's actually not a bad thing to do. So as long as you've got a good view and you can see clearly, you just follow the same principles as if you're morcellating in the bladder. You stay in the middle of the fossa, you stay away from the walls of it, you make sure that you can see properly, you follow all the safety rules as you would in the bladder, you can morcellate within the fossa. That's one option. The other option is to come, if you do en bloc, you can at any time, if you get lost around the outside, you can actually bring the scope back inside the adenoma, and you can then make an incision. You can actually do a bladder neck incision at 6 o'clock. And if you do that, you kind of spatchcock it. You can actually then spread it out a bit, and then you turn it around, and then you can much more easily get it through the bladder neck if you want. Or if that doesn't work, you can do a 6 o'clock incision and a 12 o'clock incision, and you can cut it into two pieces. And then you can get each piece through the bladder neck. So there's various ways of dealing with very big prostates. So the short answer is there's no size limit for 3-lobe versus en bloc. You can do either technique for any size prostate.
Right. Thank you so much. That was pretty much our last question. Just one last one just came through. Any advantages of the en bloc over the 3-lobe from your point of view, other than speed and efficiencies?
No. So I would say, as during the talk, there's evidence that there fairly consistent evidence published now that en bloc is faster than the 2 or 3-lobe technique, and also not quite such strong evidence, but there is becoming some consistent. A few papers now have shown the same thing, that there seems to be less blood loss, shorter catheter times for en bloc, and that also makes sense because as I said earlier, if you're not having to cut through the adenoma to do incisions, you don't get quite so much bleeding. If you just stick in the anatomical plane the whole time, as you would with en bloc, you only come across the perforating vessels, and those are usually relatively easy to identify as you come across them and to coagulate. So I think less bleeding, faster. Well, one other thing I'd say, it's actually tidier. You are more likely to do a full anatomical enucleation anteriorly if you do en bloc. What I've realized now, because I've done far more 2 and 3-lobe techniques, HoLEPs, than I have en bloc. I've now realized that I've moved to en bloc. I often was actually leaving a bit of anterior tissue behind when I was doing the 2 and 3-lobe technique. When you do en bloc, because you are forced to stay in the plane, you do a cleaner, slightly fuller, more complete HoLEP, I would say. So that maybe that's another advantage. It's a cleaner sort of operation.
Thank you. Just one last question from me, really, as you summarise this, and thank you to everyone. There's still over 120 people online still joining us, and lots of questions and interaction, which has been great. HoLEP has been around for many years. We continue to see the advances that you've seen with Moses technology and morcellation and technique and training as well. Where do you still see it standing up against the new kids on the block, as we say, when it comes to things like aquablation or even HoLEP or HoLEP as well? You showed the nice video comparing them. Where does HoLEP still stand up against those?
Well, for me personally, it's still number one. And I think, I've tried various energy sources to do enucleation, anatomical enucleation, and I'm sure maybe I'm biased and maybe I'm just too old to change now, but I much prefer the holmium, high power holmium, and I really like the pulse modulation, the Moses technology. I personally, of everything I've tried, I think it's the best. Now, in terms of other procedures, I mean, the only other procedure that kind of might rival HoLEP potential in theory in terms of the bigger prostates is perhaps aquablation. I was also involved with the water study, the earliest randomized study of TERP versus aquablation. And I gave up aquablation after that study because there was too much bleeding after the operation. So now it's changed. Now my colleagues who are doing aquablation, from what I hear, most of them are doing the water jet, passing that through, but then they're going in and they're doing a TURP as well, actually. So it's like more of a combined procedure. They're having to do that to get hemostasis, because the water jet is not hemostatic in any way at all. It just blasts a hole through the prostate, and then you have to clean up and coagulate after. So if you're prepared to do an aquablation and then also go in with a roller ball and a loop, maybe resect some tissue out, sure, you might be able to get up to maybe 150 cc's, but it's not as clean an operation as a HoLEP. And you know, that 175 cc prostate, what did that take me? 30 minutes, 30 minutes plus 15 morcellation. That's a 45-minute operation surgically. If I was doing an aquablation on that sort of size prostate, it would probably take me longer by the time I had resected tissue and got hemostasis afterwards. So I think I would still encourage people who are only offering TERP, and that's the majority of my colleagues and friends around the world for BPH. I would strongly encourage you, for all the reasons that I presented in this early on this presentation, to consider learning enucleation. And I would say, you know, I would say if you've got a different energy source but you want to learn enucleation, go ahead, learn it. And then once you know how to do the enucleation with that energy source, try other energy sources, and you will probably find, I would suggest, that you will end up wanting to use a high power laser rather than anything else. And I would say to you that with my experience in trying various energy sources, I have found that the holmium is honestly the best energy source, because it's a blunt instrument. It's a beautiful instrument for peeling, which is exactly what we're doing when we're doing enucleation.
Thank you so much. And of course, the laser can be used for stones as well from a holmium point of view. So like you said, it's taking the advantage of using what you have, building that confidence, and then moving forward. So thank you again for your time this evening. And everyone who's joined, we're still over the hundreds here as well. So again, thank you for everyone who's attended. Hopefully we've covered everything today, but we will reach out. I've put in the chat a couple of times about the Educare platform from Boston Scientific that enhances the hug group and the training that has been developed over many years by Tev Aho and a lot of our trainers out there. So please do get in, drop us a line. We do training in our Dusseldorf office, and then also can arrange mentorship and proctorship with our trainers right across the globe as well. So